Hi, I am Amanda Phillips. I am a physical therapist at Children's Hospital in Birmingham, Alabama, and I am going to be talking about the implications of developmental delay in children with cystic fibrosis in outpatient CF clinic. So this work started with a grant from the CF Foundation, the Award for Physical Therapist grant that we started back in 2017. The live stream session for this talk is going to be Wednesday, October 21st from 10 to 10:20, presented during the symposium, the PT-RT Year in Review. So I will occasionally monitor the chat throughout the conference. So if you have any questions, please put them in the Q&A box to be considered for the live panel that will happen on the 21st. And I'd love to talk to you more about this or answer any questions that you might have. So please feel free to connect with me on the network platform as well. So like I mentioned previously, this started back in 2017, and we got a grant to start including physical therapy in outpatient clinic. And the team had concerns about the youngest population, and that's really where they wanted us to start looking. We started with the group ages 0 to 5. And that was very easy to do because we see kids now in clinic starting at newborns because of the advances with newborn screen. Almost all of them are diagnosed and referred immediately. So logistically for our hospital setting, outpatient clinic, this was the age group that was the easiest to start with. So we set a QI initiative in place, and we screened all outpatient children ages 0 to 5 in clinic using one of two things, either the Ages and Stages questionnaire or the Alberta Infant Motor Scales. These are two standardized tests. The Ages and Stages is often used in pediatricians' offices. The Alberta Infant Motor Scales is predominantly a physical therapy or occupational given test. In doing this, we found a rate of delay of 27%, which was surprising. So in 2018, we expanded this. We thought, well, these were infants that we were really looking at and small young children. Maybe when they got to school age, these things sort of leveled out. Once they were around a lot of peers their same age, maybe these delays would disappear. So we decided to expand it to look at children through the age of 12. We also changed the format. We were trying to slowly adapt to a yearly evaluation model because that is what's recommended by the CF Foundation. So we kept the aims for the small children. We swapped to the Peabody Developmental Motor Scales because it's very thorough. And then we also swapped to the BOT2, which is also a very thorough test of balance, strength, agility, coordination, and a few other things. So now what we started doing, still using QI methods, we had one PT of myself that was in clinic 2 to 3 hours, 2 to 3 days a week. We used the aims for children that were birth through walking age or 18 months. If they weren't walking at 18 months, we would stop. And then from either when they started walking or when they turned 18 months old, we began using the Peabody. And we specifically looked at the subsets of that test of stationary locomotion, object manipulation, and visual motor skills. We did not include the fine motor portion. We also used the BOT2, the Brunix, for kids ages 5 through ages 12. And in those subsets, we looked at body coordination, which is bilateral coordination and balance. We looked at strength and agility, which included running speed, agility, and strength. So those are the subsets that we looked at. Also did not look at fine motor skills with the BOT2. Now for the 5 to 12-year-olds, or more specifically the 6 to 12-year-olds, we also started looking at exercise capacity, mainly because we actually had a standardized test that would measure exercise capacity, and that is something that as PTs we should be doing in CF clinic. So we were just trying to be thorough with our evals per age group of kids. So the 5 to 12-year-olds got the BOT2, and then if they happened to be 6 through 12, they were getting the BOT and a 3-minute step test. So our CF center here has about 250 kids with CF ages 0 to 21. So this was conducted over the course of about 25 months from all of 2018 through January of 2020, this January. And there were 53 children with CF that were evaluated with either the AIMS, the Peabody, or the BOT2. The reason it stops in January is because I was out of town in February a lot and missed a lot of clinic. And then in March, we had COVID hit, and we have actually not been in clinic since that because of some hospital policies and things that we're just logistically as a department trying to figure out. So that's why my data stops in January. Okay, so we tested 53 children, and 27 of them fell between the ages of 5 and 12, got the BOT. 7 of them were babies that were tested with the AIMS, and 19 of them were kind of the preschooler age, toddler age kids that got the Peabody, and those were 19. And so this is what we found. We found some sort of delay in some subset of one of those tests on a standardized test at a 46% rate. So 30 kids were within normal limits, 23 kids had a delay in some portion of one of the standardized tests that we had talked about. So in the BOT, 10 kids were delayed with that test, 10 were delayed with the Peabody, and only 3 infants were delayed using the AIMS. Now keep in mind, the 46% rate of delay doesn't mean that every single category, every single subset was delayed. It just means, like, for instance, on the BOT, they may have had a strength delay compared to other kids, but maybe their coordination was normal. Maybe they did have a delay in the whole test, but that is what that number is showing right here. Okay, this is where it gets really interesting. So this first column shows kids who had a normal step test. So remember, in the kids that were ages 6 to 12, so the ones that were getting the BOT2, they were also getting tested with the 3-minute step test as just a normal, good measure, thorough PT eval testing exercise capacity. But when we looked at their results, what we found was the kids that were normal on the 3-minute step test were also most likely to have normal scores and be within normal limits compared to their peers on the BOT2. So that's what that first set of graphs is showing. Of all of our kids that tested within normal limits on the BOT, only 3 of them had an abnormal step test. Now that was reversed with our kids who were delayed with the BOT2. So then we had kids that were showing delays in balance and coordination and strength and agility on that BOT test. And they were also showing delays on the step test. That meaning delays on the step test, meaning they were not able to complete the step test because it was just too hard, or when they did complete it, their exercise capacity was significantly less than what it should have been for their age group. So again, out of all the kids that were abnormal or delayed on the BOT2, only 2 of those children had normal step tests. So there seemed to be some sort of correlation between delays on the BOT and doing poorly on the exercise test. So what does this mean? First, why are there delays in this population? This is a neurotypical population for the most part. And now a lot of these kids, 12 and under, a lot of their pulmonary function tests are still normal or very close to normal. Of all of those that we had that were able to do pulmonary function testing, all of them were above 80, and most of them were 90% or above with their FEV1. Something that we did find, our nutritionist actually noticed this trend when she was looking at the kids, is that 60% of the kids that were delayed in some standardized tests that we did, that's all of the standardized tests that we looked at, 60% of them had a history of obesity, or they were currently considered obese based on their BMI, which was something we were not expecting to see. Contrastingly, only 31% of those had a history of obesity when they were considered within normal limits on the on the standardized test for development. The other thing that we noticed was severity of disease, or early hospitalization more specifically. Of all of our kids who were delayed on one of those standardized tests, 73% of them were hospitalized before age 3. 52% of the children that had delays were hospitalized before age 1. So it tells us that either the severity of disease is something that is causing issues in all aspects of their development, because we do know that the CFTR protein is everywhere in the whole body and skeletal muscle and all places. So is that causing something to happen? Or is it the parental stress and burden of care, which obviously would be increased if the disease severity was increased as well? The other thing is we felt that it was only fair to consider socioeconomic status, but we actually did not find really any trends in this. We had our social worker really comb through all of our kids with delays, and it seemed to be a pretty even mix for socioeconomic status. Okay, so again, the normal rate of delay per the CDC is about 15%. Now, this includes neuroatypical children. So this is going to include your kids with CP, your kids with autism, all kids with delay, not just physical delay, but mental and cognitive delay as well. So 15% is the normal rate, as close as we can tell in the normal population, it's 15%. So we had significantly higher rates of delay than that. Remember, it was 46% that had delay in some area of some standardized test. The other thing to think about is the delays in the school-age children seem to be more profound in the sense that exercise capacity is affected. So those are the ones who are tested with a bot. So we're looking at balance, coordination, strength, running speed, agility. Those are the areas that are covered at that test. Those are also the children who, when they had delays in one or more of those areas, also had significantly worse scores on the 3-minute step test. So their exercise capacity was impaired. But like I mentioned before, their PFTs were mostly normal. So it seems like it would be a very important time to intervene in these children. You could be catching them in a time where their exercise capacity is decreasing, but it hasn't been long enough to where they're seeing a lot of decline in their pulmonary function. That would be the hope, is that you could intervene then and make a difference. The good thing about that is that these delays, though they are present, these are higher level functioning kids. The delays are mild. These are not delays that are typically going to be picked up by a teacher or sometimes not even a pediatrician, because they're really kind of subtle and they might not show up until kids are really on an athletic team or on PE or at PE, and the family's like, they just fall all the time, or they just seem kind of clumsy. They just get tired more easily, but they say they can breathe. I don't think it's their lungs or anything like that. These are those kind of kids. So these are delays that you can really make a big change with quickly. This is a neurotypical population, so you can make really big progress with them with just a little bit of change, just a few things that they can work on, and you can see big progress. The problem with that, as we know with this population, is that the burden of care is very large, and any change carries an exponential effect on their life, especially if you're talking about the kids that have the more severe diseases or ones affected. Then that burden of care is already larger anyway. So it's kind of a double-edged sword, but it still is something to look at and be testing and checking with all of our kids school age, because we want them to be as involved as possible. And we want them to be as healthy as they possibly can, especially if we have these better and better drugs that are going to be trickling down to these younger age groups. So in conclusion, developmental screens can successfully be incorporated into clinic, and physical therapy is a natural fit to do this. There is a surprisingly high rate of delay found in children and infants with CF, at least at our center, but we still need to weed out why and how these delays can be corrected or prevented or even predicted. Like if we know a kid was hospitalized before age 1, we know they could potentially have a high rate of delay, and we can already be looking at these things and educating mom and dad. developmental screening really should be a part of CF interdisciplinary care because there can be long-term implications if delays are ignored. For instance, participation. If a kid that's already at risk from a chronic illness and lower participation levels feels not on the same page as their peers with things that kids like to do ages 5 through 12, which is run around and play and climb, then they could isolate themselves. It could increase anxiety and depression. It could increase social anxiety. And those are already things that we know these kids are at a higher risk for anyway. Also, their pulmonary function, because these kids so far have had pretty good pulmonary function, but they can't do a 3-minute set test. Some of them can't even finish it. So that's a big red flag too. And as we increase care in our younger populations with newborn screens, it allows us to broaden our scope of practice into developmental assessments. And that way we can really do a good job as physical therapists, taking care of these children very thoroughly from the very beginning, which I think now is even more important, again, as we have these results clinically with these drugs that are doing so many wonderful things, and we see these kids come in and they look incredibly better, the older kids. You know, if we can really get our younger population at top performance, then it can make a really big difference if and when those drugs become available to them as well. So these are the references that will help you with this slide. And I also wanted to mention, well, first I want to acknowledge UAB and Children's of Alabama. They are wonderful, wonderful people that work here. There's several physicians that have helped me with this project and encouraged physical therapy and really fought for physical therapy in our clinic. Lots of good team members to really push this along. And of course to patients and their families for welcoming not just a new face, but a new person that's telling them all these new things and asking them to do all these new crazy exercises in clinic. Also, I wanted to mention, because there are other therapists that are looking at this in clinic, and specifically Abigail Good, who is the moderator of the symposium, works at Children's of Colorado, and she is also doing these tests in clinic. She has actually been able to do this on telehealth as well. So she's going to have a lot more up-to-date data. We were trying to combine and do some sort of multidisciplinary thing, but COVID has really put a halt on a lot of that stuff. But Abigail is a great resource for anyone that has questions about doing this via telehealth. I know Matthew Bowman has also tried to do some of these standardized tests. I think specifically the P-body is what he mentioned that he was trying to do through telehealth, and has been able to have some pros and cons to that. So there are several therapists that are attempting to do this at their site. I can't speak to trying to do it via telehealth, but I know other people have. So if you have questions about that, please submit them in that Q&A panel, and we will address them, or I will make sure to get the group on that can help address those issues. So that is developmental delay in the CF clinic. And thank you for watching, and stay safe.
Hi, I'm Holly Lucen, and my presentation is on the other side of ototoxicity, understanding vestibular toxicity and vestibular impairments in cystic fibrosis. I have no relationships to disclose related to this presentation. Here are my objectives. We are going to be talking about vestibular toxicity and vestibular impairments associated with it. We will learn how to look for it and what to do to manage it when it's present. The vestibular system is a sensory processing system which includes parts of the inner ear and brain and controls balance and stabilizes gaze while we are moving. It works closely with other sensory systems, including vision, proprioception, and somatosensory systems, to provide feedback about head and body motion and positioning, equilibrium, and spatial orientation. An intact system allows us to see clearly while moving and make automatic postural adjustments to maintain our posture and stability in various conditions and during different activities. We can determine direction and speed of movement and orient with respect to gravity. This is a close-up diagram of the peripheral vestibular components of the inner ear. You can see in the middle, there's these little blue blobs with a little pink outline. Those are the utricle and saccule. They are going to detect linear acceleration of the head. And then the loops that are above it are known as the semicircular canals, and they detect rotational movement or angular velocity of the head. This occurs because hair cells are stimulated by fluid and otoliths in these organs to detect motion and orientation. The hair cells in the bottom right-hand corner are where I want you to focus on at this time. The type 1 and type 2 hair cells are what are going to be damaged from vestibular toxicity. And our central vestibular components are located in the brain, and they include the cerebellum, the vestibular nuclei, and the cortex. And they use the sensory information that comes from the peripheral system and the other somatosensory processing to integrate and process motor output to maintain balance. This busy slide is just showing you a lot of this potential causes for vestibular dysfunction. It's not just ototoxicity and vestibular toxicity, which is what we're going to be focusing on today, but many of these other things cause dysfunction, and you have to remember that when you're making your assessments that there could be another source for it. The symptoms for vestibular dysfunction are broad and somewhat vague for some of them. So the ones that are in bolded and stars are the ones I want you again to focus on, because these are symptoms that are common with vestibular toxicity. Many of them are reported during a CF pulmonary exacerbation, which makes things hard to diagnose and is one of the challenges of diagnosing vestibular dysfunction, especially without any guidelines or because the symptoms are often vague. You have headaches, nausea. Again, these are commonly reported symptoms that you would see in any patient that might be admitted for an exacerbation. Dizziness, a sense of disequilibrium or imbalance, oscillopsia, which is the visual perception that objects are moving while you are moving, or blurred vision, and then also poor memory or concentration problems. The vestibular toxicity causes damage to the hair cells from a medication or chemical. It's commonly bilateral, and the symptoms are often vague with an insidious onset. Again, it's affecting the peripheral vestibular system. Vertigo symptoms are less common, and that lack of impairment of awareness is common. And that's because, again, of the slow onset of symptoms. That, you have a general malaise, you might be a little bit dizzy or have a headache, and sometimes it's attributed to these other reasons, like just the exacerbation itself or being in bed versus a true vestibular dysfunction. In CF, they have an increased risk for this because of their frequent exposure to ototoxic medications, specifically aminoglycosides. Aminoglycosides are used for various reasons, including pulmonary exacerbations, especially when Pseudomonas aeruginosus is suspected as the cause. They are also used to manage non-tuberculous mycobacteria and for chronic suppression of bacterial growth. Aminoglycosides are the most common treatment for IV forms and nebulized for Pseudomonas and NTM infections. And per the 2018 CF registry, there was a 44% prevalence of Pseudomonas and a 13% prevalence of NTM. In that same registry, it was reported that 33% of people with CF were treated with IV antibiotics. CF guidelines recommend using dual therapy for Pseudomonas, typically using an anti-pseudomodal beta-lactam and an aminoglycoside combination. Aminoglycosides are known to have a high bactericidal effect, and they work well in synergism with the beta-lactam. The majority of people with CF have been treated with repeated courses of aminoglycosides for exacerbation. There was a study down in the 80s of 46 patients that showed that they had a lifetime of about 9 months worth of aminoglycoside treatments, or 20 courses, which is a lot. And as average lifespans increase for CF, they have more risk for increased exposure just because there's going to be more opportunity for infection. And more exposure means more exposure to potentially toxic medications. The theory behind why the aminoglycosides cause the ototoxicity is primarily based in research with the cochlea, but can be extrapolated and hypothesized for the vestibular components of the same membranous labyrinth. The toxic effect occurs in the perilymph of the cochlea, and it causes free radicals from the aminoglycosides to cause cell death and loss of inner ear cells. There's progressive damage to the sensory inner and outer hair cells, the type 1 and 2 that we mentioned on the first slide. And a study by Pana a few years ago looked at patients with CF who had been exposed to aminoglycosides specifically to look at their density of hair cells. And they found that they were significantly lower in patients that had been exposed to aminoglycosides compared to controlled groups. With aminoglycosides, all are potentially ototoxic, but some are preferential to vestibulotoxicity or cochleotoxicity. Unfortunately, tobramycin, which is the most common one used in CF, is both. Gentamicin and tobramycin are most frequently encountered in vestibular clinics related to vestibulotoxicity, and those vestibulotoxicity effects can occur after cessation of therapy. What about nebulized aminoglycosides? Well, there is minimal systemic absorption. However, it is unknown if it causes similar effects. They just really haven't had much research in this area to determine if that is going to be a factor. There are a few isolated case reports showing that patients had vestibular toxicity with nebulized tobramycin, but the research just isn't robust enough to make changes to clinical practice at this time. However, I would consider stopping nebulized treatment if you have a patient with significant dysfunction or showing functional impairments, as that additional medication is only going to add to the toxicity and perhaps worsen the dysfunction. There are some high risk factors. The evidence is limited, but some suggest that duration of exposure greater than 14 days increases the risk. We do know that typically vestibulotoxicity occurs after about 5 days of therapy. There's also a higher risk if you have concomitant use of other ototoxic agents or recent exposure to aminoglycosides. So think about your patients that have been admitted recently for an exacerbation and return a few months later. Those patients are at particular risk of developing ototoxicity. And cumulative exposure and renal dysfunction, there's mixed evidence for, but some studies say that it is a factor, some say that it isn't. It is interesting to know, though, if the renal system is impaired, that it's not going to be clearing the medication, so that there would be longer exposure to the toxicity. And increased age. As you age, everyone's vestibular systems weaken, and we already talked about having increased exposures. The literature reports the general population has an incidence rate of about, or prevalence rate of about 1.9 to 11%. But in high-risk groups, this is considered to be much larger. However, there's a lot of variability about what's being reported as far as prevalence. A 2017 systematic review by Van Heck that reviewed about 22 articles had a variable rate of 0 to 60% of patients with vestibular dysfunction. And in a pediatric oncology center that also is exposed to aminoglycoside had a 17% rate. What I want to draw attention to here is this study that was done by Handelsman out in Michigan. They looked at 71 of their patients and they tested them for vestibular dysfunction and hearing loss during exposure to IV aminoglycosides. What's important to note here is that they used laboratory equipment to confirm diagnosis, that this wasn't just bedside testing, this was laboratory testing. And what they found was alarming. 79% of their patients had vestibular dysfunction and 23% had hearing loss. So vestibular dysfunction was more prevalent in this study group. They also showed that there was no correlation between vestibular dysfunction and hearing impairment, that you could have one without the other, you could have both being negative or both being positive. So monitoring hearing is not going to be sufficient for also looking at vestibular dysfunction in this population. So if vestibular deficits are of such high prevalence, why are we just hearing about it? It's complicated. Symptoms vary. They're easily misdiagnosed during acute exacerbation, which is what I mentioned before. They're also underreported. And the brain's ability to centrally compensate for a dysfunction sometimes masks the dysfunction that's already present. So while that impairment is building, you're compensating for it and it might reach a threshold where then you're exposed and you will have functional impairments associated with it. Also, formal lab testing traditionally poses challenges because there's limited availability, it's expensive, it takes long. The lab tests are 90 minutes to 2 hours and can be uncomfortable for patients. So there are some challenges. So what should we do about it? Well, first and foremost, we need to establish vestibular screening for patients that are undergoing aminoglycoside therapy. It's really important that we determine what the baseline vestibular function is in our patients before this exposure so that we know what potentially is actually a problem versus what was already existing. We also need to be able to monitor them while they're getting their aminoglycosides or ototoxic medications to see if there's a vestibular dysfunction develop, and also to monitor them afterwards to see if there's a delayed onset. This also provides us an earlier opportunity to access vestibular rehab if we identify a problem, and also an earlier ability to remove ototoxic medications. We should consider alternative antibiotics, especially if we can't consider an ultimate change to a less toxic medication, maybe considering alternating on exposures to this medication. So if you're using aminoglycosides because it's effective, trying something else next and then going back to the aminoglycosides versus having 2 repeat exposures. And also, as we mentioned before, potentially stopping Toby or amikacin that's nebulized if you're having symptoms or the dysfunction is present and strengthening. So for screening for vestibular dysfunction, we want to start with some good subjective questions. Do they have dizziness? Is there headaches? Do they feel off balance or clumsy, unsteady, or had any falls? Do they get motion sick or have motion sensitivity? Do they ever experience changes to their vision, especially if you see things that are bouncing or bopping along, or that it gets blurry? You can target more specific questions by asking, can you read your phone while you're walking? Do you have problems reading in the car? If you scroll through a computer, to scroll through the internet, does that sometimes bother you, give you some sense of discomfort, or does a busy environment upset you? After we do our subjective testing, we can move on to vestibular bedside tests. So the 2 classic tests that we would want, at least one of these to be included in any screen for vestibular toxicity, would be the dynamic visual acuity test or the head impulse test. You also see listed here the video hit test, which is a new, promising new study that uses computer technology to actually analyze the data. It can quantify and objectify what you're seeing, and will pick up on things that might be missed on it by human error, by just the naked eye alone. Also, the video hits allow you to track changes over time, so you can monitor dysfunction for patients that don't quite classify as having dysfunction but are showing trends towards that area, or the opposite, people that are having dysfunction that are getting better, we can look at. Both the DVA and the HIT use gaze stability is what we're focusing on. One is using an eye chart, having them passively read in a station, or looking at it stationary, and then actually while someone's passively moving their head back and forth rapidly to see if they can still maintain their vision as well. And the head impulse test is doing the same thing, passively moving their head at a certain angle and stopping quickly to see how their eyes respond to that test. Central tests that we do screen for, again, to get a sense of the baseline dysfunction, are also very easy, and all these tests that I'm talking about take a couple minutes to perform. The central test battery really takes 1 to 2 minutes, just looking at ocular motor function. And it's important to see if we're establishing a baseline. And as I said, you'll see later in our data that we were finding a lot of central vestibular dysfunction signs. And finally, we have outcome measures. So there's questionnaires that patients can take to assess their symptoms and see if there's improvement or worsening over time, as well as functional tests that look at balance overall, but can be related to vestibular training as you're performing it. Frenzel goggles help improve the validity of testing. They're not quite as good as the V-HIT goggles, because they don't have the ability to analyze, objectify, and quantify data, but they can record things. You can slow it down so you can see it more easily, and you can actually show it to your patients too, so they can see what you're talking about and potentially buy into getting treatment. The laboratory tests, like they use in Handelsman, would be the rotatory chair or the caloric test. These are the ones that are high expense, take a little bit longer, and have limited availability, or accessibility, I should say, to get them. And then the promising tests, the V-HIT and the CVEMP, are much quicker, but actually have that data that they can record that is quantifiable and objectifiable, so they can show changes over time and can diagnose, confirm diagnosis of a vestibular impairment. So for our screening at Hopkins, we looked at, in the Children's Center, last year, we screened 84 patients for vestibular dysfunction and found a 54% overall positivity rate. For hospitalized children, that rate was dramatically increased, and 83% of patients that were hospitalized over the year ended up having positive dysfunction. 7 of our admitted patients were admitted multiple times, and all but 1 of them developed positive symptoms during the course of the year. 2 patients actually converted from a negative screens on the previous admission to positive on the next admission. And overall, we had 35% of our children in the hospital, or hospitalized children, that converted from a previous negative screen to a positive screen. On the next slide, the data that I want you to take out of this one would be the second column looking at the asymptomatic VD or vestibular dysfunction group. This is a group that shows dysfunction without symptoms would demonstrate that the brain is already compensating for the dysfunction. The question becomes what the threshold for symptoms is, and will repeated exposure cause that threshold to be breached? I also want to point out the patients that had the IVs stopped for toxicity or had the medical record flagged, because this was a screening success where we were able to identify patients that were experiencing symptoms or having a positive screen so that we could potentially halt that toxic exposure sooner. On this graph, the two top bar graph comparisons are showing the positive central and the positive hit, which is the peripheral signs. We had 45 patients that tested positive. 39 of them had a central sign associated with it, and 36 had a positive hit, which is the classic one for vestibular toxicity. Who is most at risk from our data? Hospitalized patients, patients that have had repeat aminoglycoside exposures within 3 months of the last dose, and anyone that's been on a long course for NTM. Also, I want to point out the aging CF population for all the reasons I mentioned before with the weakening system and being potentially exposed to more doses. But it's concerning that our pediatric population is already showing dysfunction, and what that means if it goes undetected in this adult population when they start continuing treatments there. We do need to further investigate what happens, or does the age at first exposure, especially during critical developmental periods, influence the vestibular dysfunction risk? And can airway clearance techniques like the vest contribute to dysfunction or facilitate compensations? What is the etiology for all of our central vestibular dysfunction in our children with CF? Is there something there that we need to investigate further? And how will modulator therapy impact us? If you have a positive screen, we want to alert the medical team as soon as possible to potentially modify antibiotics or stop ototoxic or vestibular toxic medications. We want to refer to vestibular PT, especially if they have symptoms, and or get confirmation from the ENT for diagnostic purposes. We also will provide vestibular education to everyone, even patients that screen negatively, so that they are aware of symptoms that they should be on the lookout, and give exercises when symptoms are present. Hair cell damage is permanent, but we can improve the residual function, and we can improve function overall for patients with vestibular impairments. We want to remove those toxic agents as soon as possible so we don't have further worsening of symptoms, help them develop central compensations like our asymptomatic group. And also of note here, the VOR can recover partially via pathways that don't require vestibular input, which is reassuring that we can gain balance and stability later. And we want to strengthen our other balance components like proprioception and muscle strength. The purpose of vestibular rehab is to promote central nervous system adaptation, compensation, and substitution when a vestibular loss is present, and to facilitate habituation of symptoms associated with vestibular loss. Here we have a patient doing an exercise that we would distribute frequently to help improve gaze stability that can work using habituation or compensations. And it's a very basic exercise to give. In summary, vestibular toxicity is overlooked, unpredictable, and often underdiagnosed. As caregivers in CF, we have shifted our primary focus from one of survival to thriving, and it's important that we monitor our own interventions to prevent harm to our patients. People are living longer with CF, so it's important that we set them up for active and productive lives. Vestibular screening can identify vestibular dysfunction earlier, so appropriate adjustments to care can be made before cumulative damage is irreparable, and we can help improve quality of life through vestibular rehab. You can reach me at this email address. Please visit poster 557. And feel free to contact me on the social networking platform or the chat feature.
Welcome, everybody. I'm Jason Fulmer. I'm the Center Director in Austin, Texas, and I'm excited to share today what I've put together regarding the state of home spirometry and cystic fibrosis. I have no disclosures. So we all know that spirometry is an important part of our evaluation of our patients. We teach our patients to use spirometry at a young age. Our patients expect this to be performed in clinic. They know we trend it, and it's an important part of our decision-making process. We use it as an endpoint in clinical trials. And in general, patients have come to expect this as part of their evaluation. Well, then hit 2020 and COVID-19, and seeing patients in clinic became a bit of a risky proposition, and doing procedures that involved generation of aerosols like spirometry became even harder. And so we're doing a lot more telehealth visits and virtual visits. And uh, with this, home spirometry has become an important part of this evaluation and something that can really help make for a better visit and a more useful visit for our patients. So let me first review the past and some of the literature out there regarding spirometry and CF. So home spirometry has been used in many different diseases outside of cystic fibrosis. But honestly, the majority of the studies are small, they're single center, the data is just not very robust. The first studies in CF were in the late 1980s out of the University of Minnesota. It'd be interesting to see what kind of device they used. I bet it's a lot different than what we have available today. Patients were asked to monitor their FVC, and they also had a symptom diary. And they did this for 4 years. And then they found that the patients that were monitored at home had a decrease in the rate of decline of lung function. They declined about 3%, whereas the standard care group defined about 11%. So a big difference. There's been studies that are small, but have shown that spirometry can be done effectively and successfully at home in adults and in children with acceptable results. There's a couple of small pilot studies showing early intervention can lead to identification of exacerbations earlier. There's a study by West, another one by Aiken. Patients were asked to monitor their lung function a couple times a week and also use an exacerbation score or questionnaire. Both found early intervention led to identification of exacerbations earlier. Both studies showed a trend in improvement in lung function, but they were small and there was no statistical significance. There's a study showing potential improvement in adherence with doing a weekly PFT and a phone call to review. The medication possession ratio increased from 60 to 65% in the patients that were monitored at home. Then here in Austin, we did a small pilot study, presented it as a poster, where we looked at how patients felt about home spirometry and what their perceptions were. And this is some of our data. So patients were asked to answer the question with a range from 1 not being useful or negative to 5 useful or a positive comment. And you can see most patients at 3 months and at 6 months found home spirometers were relatively easy to use and incorporate into their daily treatment plan, with average scores of around 4 and then 3.5. And for the most part, patients did not feel like the spirometer caused increased anxiety or worry. We know that lots of our patients have some PFT anxiety, so we wondered if this might exacerbate it at home. A low score in this situation meant low anxiety. You can see the average scores around a 2. But when you look at the individual patients, you can see here in the highlighted row, the majority of patients gave it a 1 or a 2, meaning it really didn't cause much anxiety, but there were a couple, like there was a 5 and a couple 4s. So maybe in select patients, it can cause a little bit of worry and anxiety. So I think that's something to consider as we're doing this at home more and more. The early intervention in CF exacerbation studies, by far the best data we have in home spirometry and CF. This was a large multi-center study, so 14 sites, 270 patients. Patients were asked to monitor their lung function a couple times a week and share the data. I believe they also performed a exacerbation score. And you can see patients did have more exacerbations, 57% compared to 29% in the usual care arm. So patients' exacerbations were identified earlier and more frequently. But unfortunately, the primary endpoint was lung function, and you can see there really wasn't any difference in decline in lung function over a year in the usual care arm versus the early intervention arm. Both groups declined slightly. But one possible explanation for this, if you look at the use of oral antibiotics, you can see more patients in the early intervention arm used oral antibiotics when compared to the usual care arm. So one theory is perhaps these patients were identified earlier, they maybe weren't quite so sick and weren't treated as aggressively, and this may have affected lung function over time. So just to summarize, we have studies that show that home spirometry is feasible. It can be done at home. Patients can communicate results easily, and that goes for adults and for children. I didn't mention this in some of the other studies, but in general, the adherence to protocols has not been great in these studies. I think our patients already have a lot to do, and just adding one more thing at home can be difficult for them. The studies have shown that they can identify exacerbations and drops in lung function earlier than standard care. But to date, there's not been any improvement in lung function decline over time. There's some evidence that maybe there's some improvement to adherence to therapies, and then perhaps there are a few patients that it may cause anxiety or worry in a few select patients. So where are we now? So if you Google home spirometer, there's just literally hundreds of them out there. So I put together a couple tables just to review and hit a couple highlights on some of the more common spirometers. This first table reviews devices that will give you a complete flow volume loop and expiratory flows. So they tend to be a little bit more expensive and have a little bit better connectivity and data sharing. The most common one is this MIR Spirobank. So this is the device that the foundation is providing funding for. If patients were going to pay for it out of their pocket, it was about $99. It gives you the full flow volume loop and the expiratory flows. It also has a notes and a symptom tracker on it. Training, there's videos out there as well as instruction manuals, so it's pretty good. It has good Bluetooth connectivity, and patients can download an app on their phone. This is an example of the data that they get. It's got their most recent lung function. It also has how they've quantified their symptoms, and then some trends. Data can be shared with the care center using downloading it to their phone or computer and then emailing the data. Now, the MIR Spirobank will interface with software by Zephyr RX. Now, this software costs about $15 per patient per month, and it provides a provider-facing portal. So with this, the providers can see the data. It's a little bit easier to share the data. There's also some games and incentives that go along with this software, so perhaps may make for a better effort on the patient. This is the provider-facing app, and you can see they get a flow volume loop, trends, and lung function. NuvoAir is a pretty slick device. If you have any patients that are involved in Vertex studies, some of the research studies are providing NuvoAirs for patients that can't do spirometry in clinic. It's also Bluetooth connected, and there's an app. I believe there's also a provider portal for this device. It can also track weight and symptoms. SpiroPD has been around a long time. It's a little bit more expensive. A lot of it depends on how many you order and also if insurance pays for it, but it's somewhere between $300 and $550. It's older. It doesn't have an app or Bluetooth connectivity. The device, though, the results can be uploaded to a computer and emailed. One unique thing about it is patients can set alarm and medication reminders. Now, this table shows the most common devices that are more like peak flow FEV1 monitors. They're all relatively similar. They tend to be less expensive. The majority have to be uploaded or downloaded to the computer and emailed. Only the MIR Smart one has a Bluetooth connectivity. The most common one that I've seen used is the MicroLife, and it's about $75, and it works pretty well. The CF Foundation has put out some guidelines or recommendations about best practices. They're pretty common sense type stuff. You know, make sure that the RT or someone on the staff knows how to use the device and can help and instruct the patients. Care teams really should check with the patients before they order them a device to make sure that they really want one and they're going to use it. And then once they get it, care teams need to educate the patients on how to use it and how often they want them to share the data, if they want to enroll them in any kind of provider dashboard versus just email and obtain the data that way. And then lastly, care teams really should look at how to bill for setting up these programs and interpreting results. So I want to kind of get a sense of where we are with home spirometry. So I sent out this survey to different providers. And so we, at the time of putting these slides together, had around 63 responses from different centers. And you see there's a mix of pediatric and adult sites and a mix of size of centers from small, medium to large centers that responded. And I'll just kind of hit some of the highlights of the data. So you can see at this time, around 20 to 60% of, the majority of centers have around 20 to 60% of their patients using a home spirometer. The most common is about a third of patients using a home spirometer. I suspect as the CF Foundation continues to roll out their program of providing spirometers, these numbers will increase. These are the most common devices being used. By far the most common is the MIR Spirobank, as it's being provided by the foundation. You can see there's a decent chunk of our patients that have a Spiro PD or a MicroLife device, and then a smattering of some of the other devices. I asked centers how they educate their patients on using their home spirometer, and almost 90% uses direct education from a RT or another provider to the patient. Quite a few centers use instructional videos that are out there and available, and a small portion don't have any kind of formal education process. When asked how often do you instruct patients to use their spirometer, the vast majority recommend using several times a week, but not every day. It's about 2/3. I was a little bit surprised that almost a third of centers have asked their patients only to use the device when they're symptomatic. Let me walk you through this slide. It's a little bit confusing. This was how do you get the results from the patient? And of course, different patients may choose different ways to get the providers their results. So I asked providers to rank from 1 being the most common to 4 being the least common. You can see the most common way that centers get results right now are through email. The patient will download and then email to the provider. Second most common is actually doing the spirometry during the telehealth visit and showing the results to the provider. Third is a verbal report, just telling them what the results were. And then lastly, utilizing apps or platforms provided by the manufacturer. And I think this probably is the least common just because of the expense associated with it. So I asked providers how they really feel about using a home spirometer. Do they think it's useful? And you see around 2/3 of providers felt it was a beneficial, useful thing. I was a little bit surprised that almost a third of providers were somewhat indifferent in using home spirometry right now, but very few were negative. And as far as comments go, most found it, most common comments were that it's a useful tool for virtual visits, it's useful for triaging patients, determining when to come in, and it may improve patient engagement in their healthcare and can lead to earlier interventions. So I sent out a separate study to patients. These are just patients in the Austin Center, adults and peds, just to kind of see what they felt about home spirometry in this current day and age. So we had 43 responses at the time of putting this together, and I can't hit all the questions, but I'll hit the highlights. I'm sharing this because in Austin, we need to do a better job with education. We have about 18% of our patients that stated they didn't get any formal education on their device. So that's something we need to work on. In general, patients were more positive than providers as far as using the device. Almost 80% felt like it was useful in managing their CF. There were a few that were indifferent and very few that felt negative towards the home spirometer. And the benefits were just kind of what you would expect, having real numbers, objective measures, following trends. They felt it improved telehealth, early indicators and interventions, and some felt it helped with worry over their health. So maybe if they had a bit of a cough, they could do their spirometry and feel reassured if their lung function hadn't dropped. By far, the most common drawback or concern was accuracy. So I think it's important once we all start seeing patients back in clinic again to make sure they bring their spirometer with them and check and compare it to our in-clinic device. Well, what's the future? Well, I don't have a crystal ball, But I think telehealth is likely here to stay. And I think home spirometry is an important part of that and can help make telehealth visits better. I mean, our patients like telehealth, to be honest with you. Certainly there's less infection control risks. There's most likely less expense to the patients and also less travel burden. Additionally, with patients on triple combination therapy, I think there's going to be fewer in-clinic visits, and there's going to be a need for monitoring patients between clinic visits. I think reimbursement will be important for interpretation and setting up these programs. Sites will need this to help support the time and work required to do it. Hopefully, there'll be better reimbursement for devices because, right now we're lucky to have the CF Foundation provide devices, but over time they'll break or be lost and need to be replaced. And so hopefully at some point, insurance companies will start covering reimbursement. And then finally, I think equipment's going to get better. It's going to be easier to use, apps, connectivity to phones, easier to share, and hopefully at some point integration into our EMRs. So with that, I want to thank you for your attention, and I'm happy to answer any questions.
Good morning, everyone. My name is Richard Belkin. I am the Medical Director of the Adult Cystic Fibrosis Program at Santa Barbara Cottage Hospital. Welcome to the fourth and final talk during the PT-RT Year in Review, where we are and where we are going. First, I would like to thank the moderators, Cheyenne Pye and Abigail Good, for asking me to speak today as part of this exciting session. I will be reviewing our Quality Improvement Initiative, accelerated implementation of the telemedicine virtual visit program at a community hospital cystic fibrosis program during the COVID-19 pandemic. I hope that no matter where you are in your virtual care program development, there will be some tidbits of information which you can, quote, steal shamelessly and apply to your clinic, and I hope to learn from you as well. I will occasionally monitor the chat throughout the conference, so please contribute to discussion there. And please connect with me on the networking platform as well. There are no relationships to disclose related to this presentation. I would like to start off with a quote from one of our patients about virtual visits. I like the ease of not having to leave home. I also like the fact that I'm not exposed to other CF bacteria while performing the virtual visit. I have a thermometer, blood pressure cuff, a spirometer, thanks to the CF Foundation, and a scale. So I'm able to provide that information to the clinic at a virtual visit. This quote really illustrates a number of the benefits of virtual visits. What is telehealth versus telemedicine versus virtual care? These terms are often used interchangeably in the literature, and I will define them here. Telemedicine is the practice of medicine using technology to deliver care at a distance. Physician is in one location and uses a telecommunications infrastructure to deliver care to a patient at a distant site. These typically involve remote clinical services and are typically audio-video, but can be audio only. Telehealth refers to electronic and telecommunication technologies and services used to provide care and services at distance, but is really a broader scope, including clinical and non-clinical services. Virtual visits, or more broadly care, is a way of talking about all the ways patients and doctors can use digital tools to communicate in real time. While telemedicine refers to long-distance patient care, virtual care is a much broader term that refers to a variety of digital healthcare services. There are many benefits as well as barriers to the institution of virtual care. Some of the benefits include increased continuity of care, convenience, reduced no-shows, access beyond normal clinic hours, increased billable hours, reduced patient travel burden, particularly for those that are geographically distant from clinic, increased clinic efficiency and the ability to see more patients in a clinic day, improved patient satisfaction, improved infection control just by the mere fact that less patients are coming into clinic, and the potential for a reduction in overhead with the need potentially for less staff or space and the ability to work remotely, including from home. The barriers have really been long-standing and have included financial and reimbursement, where virtual care has not been reimbursed at the same level as in-person care, interstate licensure with the inability of seeing patients across state lines, security, privacy, and confidentiality issues, particularly with HIPAA-compliant platforms, equipment needs for patients and providers, and technical issues during visits, and now with the COVID-19 pandemic, spatial distancing being required for providers in clinic. Santa Barbara Cottage Hospital and Ventura County Medical Centers embarked together on our virtual care initiative in October 2019 at the North American Cystic Fibrosis Conference, supported by the Virtual Improvement Fundamentals course, the Dartmouth Microsystem Academy, and Cystic Fibrosis Foundation. This is our initial virtual visit flow map, or 1,000-foot view, which is an overview of the development of our virtual care program. This is clearly a busy virtual flow map with lots of various issues addressed regarding the institution of a virtual visit program. This was developed before the COVID-19 pandemic. We really tried to focus on defining which patients would benefit most. We identified appropriate equipment, staffing, coding, reimbursement. Clinic flow with multidisciplinary team member involvement was addressed in detail. The hope was that addressing all of these issues would lead to a successful virtual visit. In March 2020, with the onset of the COVID-19 pandemic, we had rapid acceleration of our virtual visit program to complete virtual care, with our last in-person clinic day, February 25th, and first complete virtual clinic day, March 10th. We then developed a more streamlined flow map to see essentially all of our patients virtually. We focused on 4 areas. 1, virtual visit platform, which had to be approved by our hospital administration, but one that was highly functional. Obtaining adequate IT support from our hospital, training patients on how to use the platform appropriately, and then working on clinic visit flow and inter-team communication with the designation of a team quarterback, with secure messaging system to assist with inter-team communication, with team members being remote. We currently use secure chat through Epic to assist with inter-team communication. Here is our Dartmouth microsystem improvement ramp with global aim, specific aim, change ideas, and measures. Our goals initially in the program were to maintain CF clinic utilization virtually to the same level as in person, to ensure and measure patient satisfaction and experience of care as measured by unengaged time for patients during a virtual visit, and to assess provider satisfaction and to begin to address issues regarding proper coding and reimbursement to ensure long-term sustainability of our program. Here is a list of the equipment needed for a successful virtual visit, which we sent to patients and families in preparation for virtual visits. This included a scale, blood pressure cuff, pulse oximeter, thermometer, of course our spirometer, which is supported by the CF Foundation, and to ensure that they had virtual care electronic devices. On the right is a handout we provided to our patients to assist them with obtaining the appropriate equipment. Here is another very detailed virtual visit flow index created by the CF Foundation, which is extremely helpful no matter where you are in your virtual visit program development, starting from telehealth prep through pre-visit planning, pre-visit check-in, telehealth visit flow, and ways to obtain cultures and labs, as well as a post-visit follow-up and assessing experience of care. We then assessed what we thought would be good measures of success. In the short term, we looked at utilization rates, patient experience of care as measured by unengaged patient time during a virtual visit, and provider satisfaction. In discussions with Randy Messier from the CF Foundation, who really helped me think about long-term measures of success in 3 areas. This included health outcomes, clinical areas, including potentially decrease in pulmonary exacerbations, increase in FEV1 or BMI, financial success, which would require virtual visit reimbursement of facility and non-facility professional fees to be the same as in clinic, and third, operational efficiencies. In my opinion, having a highly functioning, easy-to-use audio-video platform with adequate technological IT support is of paramount importance for a successful program. So a little bit more on the virtual care platform venue. As mentioned, this is a key component to the success of a virtual care program. Usability of the platform, customer service, potential integration with your EHR, and security issues are all important to address when picking a platform. We at Cottage have tried various platforms and are currently on Doxy.me, which unfortunately is not a highly functioning platform for a multidisciplinary visit with many dropped audio-video calls and difficulty having multiple team members present virtually during the visit. Unfortunately, we've been unable to use Zoom due to initial issues with Zoom and privacy issues at the onset of the pandemic, but these have since been corrected. I have used Zoom, however, in my private pulmonary practice, and it integrates extremely well with our electronic health record named Elation. With excellent share screen function, it can accommodate a multidisciplinary visit and has very few dropped audio-video calls. It has a virtual waiting room, and I believe is the best platform currently, and the one I recommend if you have access to it at your CF center. So the technology required for patients includes any device capable of audio and video transmission, smartphone, tablet, laptop, desktop with a webcam. On the provider side, ideally a 2-monitor system with audio-video capability, including a webcam, or a computer and separate device with audio-video such as an iPad or a smartphone. The following changes in government regulations have been key to success of virtual care. Medicare expanded telehealth benefits under the 1135 waiver authority, which is effective March 6th, and it's will be effective through October 23rd and may be extended longer. And this includes the waiver of virtual visit requirements for the originating distant site. Virtual visit reimbursement is now on par with in-person services. HIPAA regulations have been loosened. Out-of-state providers do not need to be licensed in the state where they provide services. Telephone audio codes are now reimbursable by CMS, and virtual visits are allowed not only for established patients, but for new patients. And now we have the ability to bill for remote patient monitoring, which is a great way to increase revenue for your CF clinic. Here you will see our virtual visit utilization data. There were 106 total in-clinic visits at Cottage from October 2019 through February 2020. March was considered a transition month. We had 146 visits from April 2020 through August 2020, of which 143 were virtual and 3 were in clinic. As you can see, we're able to accommodate more patients since the onset of the pandemic. Potential reasons for this include increased clinic efficiency, as well as shorter visit times given the remote nature of the visits. We assessed provider feedback by SurveyMonkey. All providers felt virtual visit increased access. Over 75% felt improved patient care. Just under 75% were interested in virtual group education, and most providers would like to continue virtual visits. The survey was done in May 2020, and I believe the percentages will be even higher now that we have more experience with virtual care. Here are the results of our patient satisfaction survey, which were performed in both May and August of 2020. Patients who live far away, over 75% were interested in virtual visits. 75% felt that they had increased access to care with virtual visits. Almost all patients felt virtual visits would improve the patient-physician relationship in a positive way. And over 75% understood the plan of care with virtual visits and had questions answered and felt the platform was easy to use. As you can see on the repeat survey, patient satisfaction survey, these areas either remain the same or improved. Some comments and concerns on the provider side. So some pros: fewer canceled appointments, nice to see patients in their own environment. Cons: lack of personal connection, and more of a concern with unestablished patients versus established patients. Some comments and concerns from our patients. A pro: don't have to sit in traffic, is likely related to the convenience of virtual visits. Virtual and in-office visits are a good combination. This goes along with the notion that hybrid clinics in the future will likely be instituted at many programs. On the con side, internet connection, delayed audio video for some. This supports choosing a highly functioning platform is of utmost importance. Inability to perform PFTs is changing with the advent of home spirometry and supply of home spirometers to our patients. Miss the personal connection. We are working on reopening and getting back to a combination of in-clinic and virtual visits. Here is a run graph of our unengaged time in clinic versus virtual care. Unengaged time here really is a surrogate marker for patient experience of care. Last year, we instituted various change measures with PDSA cycles, which included institution of a whiteboard and a team member designated as a quarterback to help improve inter-team communication with significant reduction in our unengaged time. We have been able to maintain this with virtual care with the continued use of a quarterback, which is a designated team member who helps with inter-team communication and uses secure messaging. As you can see, our median virtual visit unengaged time was 15 minutes, which is very comparable to the 14 minutes of in-clinic time. Financial impact. This is a big one for long-term success and viability of a virtual care program. There currently, from a professional fee standpoint, has been no significant impact on evaluation and management codes. We've been able to see more patients with virtual visits, 106 in person versus 139 virtual and 3 in person, 5 months before compared to 5 months after the pandemic started. The loss of revenue really comes in office testing, including flow volume loop and 6-minute walk test. The gain in revenue is in areas such as remote patient monitoring with home spirometry setup, as well as the use of chronic care management codes. For facility fees, there really has been no impact on facility visits other than reduction in testing, which include full volume loop, 6-minute walk test, sputum cultures, imaging studies, etc. Listed here are very important ways to help maintain revenue with virtual care at your CF clinic. This includes the virtual visits, which are billed in a similar fashion to in-clinic visits with the same CPT codes, but with the addition of place of service coding modifiers. Practitioners working in a facility will be paid facility rates. Practitioners working in a non-facility will be paid office non-facility rates. The next category are virtual check-ins. These are phone call or images or videos sent in or reviewed asynchronously. This can be for newer established patients. It's patient initiated. There needs to be consent for check-in and can use everyday technology. And it has to be unrelated to evaluation and management code. E-visits are HIPAA-compliant patient portal secure messaging visits. For established patients only, patient-initiated, can use everyday technology, and codes are cumulative over 7 days and unrelated to evaluation and management visits in the next 24 hours. These can be billed by both physicians and non-physicians, and respiratory therapists and physical therapists count as qualified non-physicians and can bill these codes. Telephone calls are also important ways to maintain revenue. This can be for newer established patients with consent, may be provided to family members, and is unrelated to evaluation and management codes. And again, can be billed by both physicians as well as qualified non-physicians. A little bit more about remote patient monitoring. These are a great way to capture additional revenue for services such as home spirometry setup and teaching, as well as home spirometry monitoring, particularly as we lose in-office testing such as flow volume loops and 6-minute walk tests with virtual care. You can see here the various non-facility and facility reimbursement rates. These codes, again, can be billed by qualified healthcare providers, which would include both physicians and non-physicians. And these bills, however, some of them cannot be billed simultaneously with chronic care management codes as noted. As you can see here, if you build 99453, which would be for initial setup of a home spirometer, and 99091, which is collection interpretation of transmitted data over a 30-day period for 75 patients at a CF clinic, this could bring in close to $6,000 in revenue for your CF clinic. So, in summary, our virtual visit program is something we were developing even pre-pandemic and has many benefits even outside of the pandemic. Our CF team at Warp Speed implemented our virtual visit program with the support of our hospital administration. All CF centers have rapidly integrated virtual care to varying degrees at their CF centers. Operational efficiencies will need to continue to be addressed, specifically improved audiovisual HIPAA-compliant platforms and access to them, as well as instituting hybrid clinics moving forward. Clinical benefits will need to be addressed, including potential reduction in FEV1, BMI, and decrease in pulmonary exacerbations. Financial limitations will drive long-term sustainability. This is still somewhat of an unknown, and the hope is virtual visit reimbursements will remain on par with in-clinic visits. But I do suggest that you take advantage of some of the new billing codes of remote patient monitoring to increase revenue for your clinic. Some acknowledgements. I would like to acknowledge here support from the CF Foundation and Dartmouth Microsystem Academy through the Fund to One CF LLC Virtual Improvement Program. Our quality improvement initiatives are also presented in poster number 692. I would like to thank Randy Messier, Cheyenne Pai, Bob Zanni, who have been wonderful quality coaches to myself and our CF team. My contact information is listed here, and please do not hesitate to contact me with any questions or comments or thoughts on virtual care. Thank you for joining me today, and I hope you have an enjoyable rest of the virtual conference.